Welcome to Holy Health, the podcast where cutting-edge health insights meet timeless biblical wisdom. Join us as we explore the latest in wellness, fitness, and mental health, all while grounding our journey in the spiritual truths and guidance found in the Torah. Whether you're looking to nourish your body, mind, or soul, we'll help you live a life of balance, vitality, and faith. Tune in to discover how to achieve holistic health through the perfect blend of modern science and ancient wisdom. Let's dive into the fullness of life, body, and spirit together. Hey guys, welcome back to Holy Health and what is going to be our final episode before spring break. Whether your spring break is the holiday of Passover, whether your spring break is the holiday of Easter, I want to wish you guys a happy and healthy holiday season. This week's episode is a topic that I think you will all find as fascinating as I did. Dr. Jonathan Weisen, who is a neighbor of mine here in Efrat, I joined LinkedIn about maybe 2 months ago, and I connected with Dr. Wiesen, and I saw that he'd written a post about the topic of polypharmacy, and I found that really interesting because we all know, whether it's a parent, whether it's a relative, a friend, people who are taking multiple medications. There are people that have these little boxes, that show how many times a day with a few pills in each one. And very often over the years, people have, start with one medication, another is added, and then a new symptom pops up and something else is added for that. And very often these medications can have side effects between them that are not always pleasant. And sometimes they'll create almost a new symptom that will then be medicated for as well. And I felt like this is a topic that we could all learn something about, we could all benefit from, and I'm sure you guys are going to enjoy it as much as I did. So a little about Dr. Wiesen. Dr. Jonathan Wiesen is a pulmonary and critical care physician. He's passionate about clinical medicine, innovation, and medical technology. Dr. Wiesen graduated from the Albert Einstein College of Medicine with a distinction in research and completed his training in internal medicine and pulmonary critical care at the Cleveland Clinic, where he earned an advanced teaching degree as well as several teaching and research awards. As a third-year fellow, Dr. Wiesen founded MediOrbis, a global telemedicine company, which has been a leader in the provision of unique and cutting-edge clinical services and programs. MediOrbis received recognition for innovation by the American Telemedicine Association and was selected as one of the top 10 telemedicine companies worldwide in 2019. As the chief medical officer, Dr. Wiesen has spearheaded the development of innovative clinical programs for the monitoring and management of chronic medical conditions and for the provision of integrated medical specialty services. Dr. Wiesen has also overseen the development of a global network of physicians to deliver outstanding telemedicine services worldwide. In addition to telemedicine, Dr. Wiesen is actively involved in advising and assessing medical technology companies. Dr. Wiesen remains an active physician who is passionate about clinical medicine. He has an academic appointment and is the director of cardiopulmonary exercise program at Ben-Gurion University. So for our Torah Extra this week, we have Rabbi Peretz Segal back again. I'm sure you guys remember he's done several topics. I know one of them was sauna. I think one of them was the truth about the sun. But every time he comes on, he gives a fascinating tie-in to whatever our subject is to Torah. His Torah is always interesting. It's always engaging. And I just love the things that he has to say. So Rabbi Peretz Segal was born in Johannesburg, South Africa, and educated at the King David School in Victory Park. He joined the Center Program Staff, a division of Or Sameach Jerusalem, in 1998, and today he serves as a senior lecturer and mashgiach on the program. He's the author of Vagueness Vanquished. He's the founder and mashgiach of Kollel Eitz Pre and Academy of Life Training, and a lecturer at Ner LaElef or La Gola and the Jerusalem Kollel. Rabbi Segal lives with his wife and family in Jerusalem. And both of them, all of their links will be at the end of this episode if you want to be in touch or connect with either one of them. And after the Passover holiday, we will be getting back with a whole variety of new topics. Not always as we've gone in the past, a lot of the topics seem to be sort of, I guess we could call them biohack related or whatever many people are talking about, whether it's menopause or hormones. I'm going to be delving into some topics that seem almost normal, but looking at them from an alternative perspective. One of the ones I'm really excited about is pain and how pain is driven by your brain. So, you all know people who probably take, or you yourself may take different medications for pain, but there are other ways to get your body out of pain. And we're going to be exploring that. And I'm really excited about that episode as well. So if you have any topics that interest you, please reach out. I'm constantly trying to reach out to different people about different topics to try to get interviews. And I'm always looking for new people to come on and help me with these Torah extras as well. If you feel like you have something to contribute, either as someone to be interviewed for a topic or as a Torah extra, I'd love to hear from you. And until then, I'm wishing you a happy Passover or a happy Easter, whatever it is you might be celebrating. I'm really excited to have Dr. Jonathan Wiesen with me here today. I'm having a little bit of an issue. I had a dental procedure yesterday, so if you're watching and my face looks swollen or I'm speaking a little bit funny, like those words I couldn't get out, that's possibly why.
Well,
And
we're not here to discuss the dental issue because that's not exactly what your expertise.
no, and no. I already had to discuss it with my daughter-in-law's father because he does these same procedures in New York. I needed to make sure it was done well. So, yeah. No. We are here.
So good.
Oh, thank you so much. So we are actually here today to discuss polypharmacy. And I got into to LinkedIn, I don't know, about a month and a half ago, and I just started trying to connect with any name of someone I knew, that came up across my screen. And I saw a post that you'd written. We are pretty much neighbors. We live down the road from each other in a frat. And I saw this really interesting post that Jonathan had written on polypharmacy. So we are here today to discuss that topic.
All right. So why don't you let her rip?
You got it. So let's start with the obvious. What is polypharmacy?
Sure. So polypharmacy is I guess the situation or the reality of patients being prescribed many medications. So again, just breaking it down a little bit, there's no, I don't think, specific definition indicating that they have to be excessive medications or extra medications or unnecessary medications. I don't think that there's a strict cutoff, like 7 is not polypharmacy, but 8 is. It really just relates to the phenomenon that's taking place in healthcare today of prescribing more medications than probably is necessary or indicated for a particular patient in front of you. Now, this particular post came to be as it related to medications that can cause sedation in elderly and geriatric patients. It also related to prescribing medications that may be off-label, which means that they aren't necessarily cleared and they don't have FDA approval for a certain indication, but they're being prescribed for that anyway. And so there are many different issues that are negative for patients that polypharmacy touches on. But for me, the most important thing is just intellectual honesty and integrity. If a patient needs one medication, then it's your job as a doctor to give them that medication. And if they only need one and you give them 2, then you're neglecting your responsibility to the patient as their provider and as their physician. And that's, I think more than anything, of course, the other things are a big deal, but to me internally, in my kishkas, in my core, I want people to be practicing the right way and to be doing the right thing for the patient, regardless of how much time, effort, distraction, or whatever it is that it causes.
Okay, well, that absolutely makes a lot of sense to me. But do you find that when people are going to a number of different specialists and each one is sort of prescribing their one medication, that that's part of the problem? I guess because what hit me as I was reading that was that my family was going through something a little bit similar because my aunt is in Florida. Well, I hope she doesn't mind that I say this, but anyway, she's in Florida and she was in the hospital, and my father's a doctor also. And she was on so many different medications from a number of different doctors. And when my father started looking at it, there were like so many interactions between these medications that it was like causing other problems.
Right. So one issue is definitely medication interaction. Once you start prescribing multiple different medications, then you increase the chances that there'll be a negative interaction between the medications. Now, there are multiple different types of interactions. One could be in terms of symptoms. So if you prescribe two medications that cause an upset stomach, you've now doubled the chance of the patient having upset stomach, or doubled the severity of that upset stomach. It could be something where there's actually an interaction on the pharmacokinetics of the medication, which means that taking one medication may actually boost the utility, or on the flip side, may actually reduce the utility of a medication. And that's very dangerous. If you have a particular dosage that's recommended for a medication, and now all of a sudden you're doubling the effective dose, right? You're like 500 milligrams of azithromycin is the right dose. But now we're giving them double that. You're potentially setting the patient up for more adverse effects. So there are a lot of different ways in which these medications can interact and cause harm, and all of those are increased as you increase the prescription number and frequency. I will tell you one thing though, that there are so many interactions between medications that it's extremely hard to know when there are actually meaningful interactions and when they're not. I still remember, I tell the story all the time, the first night that I was on call, a patient had a low calcium level. And so I was just trying to prescribe them some supplemental calcium to boost their levels. So I put in a prescription, I put in this amount, and it said, oh, it interacts with the antibiotic that they're on. And I said, oh, okay, well, let me try a different formulation. Like, nope, that interacts with a different medication that they're on. Like, okay, what about this one? Nope, also another interaction. And I'm sitting there dumbfounded, like, what am I supposed to do? Because it seems like calcium has some interaction with all their medications. And one of my senior residents came over, and I was like, what do I do? He said, oh, you just click through. Who cares? Ignore it.
Wow.
Because there are so many
Right.
interactions between medications. So if there's a 0.0001 interaction with one medication with another medication, does that mean you can't prescribe them together? I don't know. You prescribe it like a million times, but you'll have one interaction. Or if it's not a severe interaction, who cares if they interact? So it is complex because, again, on the simplistic side, when people on social media are just throwing out, clickbait headlines, they'll say, oh, doctors are not aware of all the prescription medication interactions that their patients have, which is partially true. But the reality is that because there are so many interactions between all the different medications, it's nearly impossible to take care of a complex patient without there being some hypothetical possibility interaction between two of the multiple medications that they're going to be prescribed.
Okay, well, it makes a lot of sense. And you actually said something interesting when you said that the senior resident told you just to click through. I was thinking I was brilliant and I was wondering why nobody had created an app or something where, someone's in charge of all the medication. So clearly that system existed even when you were a resident, however many years ago that was.
Yeah,
So in
and
other words, clear.
yeah, when I was a med student, we had our what were they? We had our little like tablets, like the pre-tablet tablets,
Mhm.
uh, like pre-BlackBerry, when you had those little tabs and they had these applications where you could put in two medications and see if they interacted. And we would do that all the time. We would spend, I'm not exaggerating by saying you would
Right.
spend maybe 30 minutes every day just looking up, I think it was Lexicomp, to see if there was an interaction between the two. But like, you can't spend 30 minutes a day every day just looking up interactions. So at a certain point, you have to say, yeah, it's probably not a big deal. But again, there are companies that are out there. There's a company in Israel, and there are multiple electronic medical record and pharmacy benefit companies that are implementing technology to say, not just are there interactions, but are there meaningful interactions? Are there a lot of interactions? Using technology to figure out, okay, of the 100,000 potential interactions, what are the one or two that you really have to look out for? That's really important and that's really useful. But yeah, it's something that we've known about, right? It used to be you memorized them, then you got to like the little applications on your tablets, and then, now you have it part of the EMR. Soon it's going to be AI driven. But in all of those instances, it's an attempt for doctors to get extra tools to avoid this from happening.
Okay. So that makes a lot of sense. And do you find though that sometimes a different doctor, let's take Israel for an example, where you go to your local kupa and you may not always see the same doctor. Now, interesting enough though, I think that if you're, let's say, Mochadet or whatever kupa you're on, once it goes into the system, I think any doctor that would ever pull up your Mochadet file, I think would see everything you're on anyways, I think, because I feel like it is, we don't have that same HIPAA that they have in America. So I feel like it is centrally located in the Milchedet thing. But you may not always see the same doctor. So let's just say, patient comes in and they're on all these medications. And like you're saying, they have a side effect of, I don't know, a severe headache or whatever the side effect might be. But it seems like something new is going on. So then the doctor prescribes something to treat that symptom, which is really being caused by an interaction between the medication. Like, do you find that that goes on a lot, or you have to do that because, like you're saying, certain medications people need?
Again, it really depends on the clinical situation and the circumstances. You touched on a couple of issues. The first is interoperability and shared electronic records. So for sure, Israel is one of the leaders in the world in the fact that they have electronic medical records for all of their citizens across all the different HMOs. So that's already a head start. They're doing things the right way. They're heading in the right direction. But at the same time, it still doesn't give you 100% accuracy. I get little notes sometimes for patients that saw a doctor privately, and the doctor's not paying for an EMR, right? Those cost tens of thousands of dollars a year. So he's just like writing on a piece of paper. He doesn't have a full list necessarily of all their medications and their whole health record. So it's not 100% anywhere, but it's pretty close here. But yeah, for sure, if one prescriber does not have access to what the other prescriber is doing, it's inherently going to increase the risk and the potential for side effects and interactions. But again, even when you have a completely integrated health record, you'll still see that you'll have multiple medications for any one particular patient. As this article is pointing out, particularly in elderly patients and particularly in complex patients, because it's almost impossible to get to, let's say, 5, 6, 7 medications that don't have at least some potential interaction.
Okay, so let me ask you, what about like natural products or vitamins or minerals or supplements that people might be taking? Can
Of
those
course, there are
interfere,
interactions.
interact?
Some we know, some we don't know. That when I was in when I was taking my pharmacy class in medical school, I could tell you like every single supplement that we know
Hmm.
that will interact with medications.
Hmm.
Ginkgo biloba and the St. John's wort and like all of these that could potentially interact with known medications. But part of FDA controlled substances uh, is that they're not controlled by the FDA, and we don't necessarily have the data or evidence to know what they are or not interacting with. And it's a real problem because if we know, right, we know about polypharmacy and we know about interactions, and that's tracked, and there's technology to control it, and it's still a huge problem. Certainly, when you have like all these other, non-FDA controlled substances, organic products that we don't know about, obviously they're going to be, it just opens up the opportunity and possibility of interaction even more so. So yeah, it's a real problem, and I don't necessarily know if we have a great solution because like I said, it's a huge problem even under the compounds that we know about. So
Right.
I don't even know where you start with the ones that we don't know about.
No, because I'm gonna say they're coming out with like new things all the time. So, that definitely makes sense. So do you feel it's important for anybody who might be listening that if people are taking medications that they actually let their doctor know what supplements they might be taking as well?
Yeah, this is like the last 10 seconds of every commercial in the United States where the guy says, let your doctor know if you're experiencing these side effects. Yeah, I mean, I will say that it's really important. I'll also say that it's not necessarily the case that your doctor we'll know, what that interaction is. And that's part of, what's exciting about technology. There's a whole lot of ink spilled on AI and technology and healthcare and how it's going to help. For sure, for sure. The way it's going to be really useful is finding out those rare interactions. So I always use the example of like pregnancy and safety of medications. Right now there's like this archaic old ABCDE system that is clinically useless. I mean, it's useful if you look at the tab and you say, oh, okay, it's going to cause some sort of teratogenic properties. Like, okay, fine, absolutely don't take it. Don't drink alcohol when you're pregnant. We know that for a fact. Um, but for the majority of medications, like the sample size of pregnant women is just too small for us to know if there's really a signal, there's really an impact. So we're going to get big data and we'll get computer generated learning, deep learning, to see if they can tease out those associations over the course of a massive population. So I think that'll be really useful. And I think this is a good example of that. Maybe we'll be able to get a database of everyone taking St. John's wort. And we'll be able to put that together and say like, oh, everyone taking St. John's wort is also getting muscle pains when they take a statin, or also getting a cough when they take an ACE inhibitor, or also, et cetera, et cetera, et cetera. That's, I think, one of the exciting promises of technology, that it can help us figure out where there are interactions and when we have to be really careful about it.
Do you think that sometimes when people are getting bad side effects, maybe it's not the medication, maybe it's really something else that they're taking?
You'd even
I
say
guess it's like a theoretical,
right?
like
Sometimes you think it's something else, but it's really just a simple medication question. I'll tell you a story of a friend of mine who called me up. No one's perfect. I'm certainly not perfect. And I still remember I was going skiing with my family, and he called me in the airport. And he called me. I didn't pick up. He texted me like, "Hey, I really need to talk to you." So I'm like in the airport with, with my, at the time we had 4 kids, and we were like going skiing with all of our garbage and like our bags. And he's like, "Hey, my mother's having like these really bad muscle pains, and I don't know what to do about it." And so of course I start going into overdrive, right? I'm trained at the Cleveland Clinic. You start getting your differential diagnosis, generating all the possibilities. And I'm going through everything with him. I'm like, order this test and that test and this test, and it could be rheumatological disease, it could be inflammatory, it could be autoimmune. I'm going through the whole thing. And he's like, okay, thank you so much. I know you're busy. That was the end of the call. I call him back a couple days later. I like to check in, when people
right.
ask me questions just to see how they're doing. And he said, oh yeah, it was just my mother just had a bad reaction to her statin. So her primary care doctor had just started. I don't remember, it was simvastatin, atorvastatin, and she had side effects, which is muscle cramps and aches. So it was like a very simple thing. So yeah, you could definitely have complaints that seem like they're a big deal and big systemic issue, but it's really just like a small medication issue. And you could also have, on the flip side, again, you could have side effects. You could have like real serious issues going on, and it's not related to the medication that you're taking.
Right. Right. So I guess that's when you have to thoroughly check it out, because it's not always easy to know.
Yeah, one of my mentors once told me, one of my preceptors, he said, if you start a medication and a patient has a side effect, assume it's the medication unless proven otherwise. If there's a temporal association, it sort of makes sense. But other than that, again, people get side effects. People get severe side effects. There's something called angioedema, where your face swells up, or your tongue swells up, your lips swell up, and it's a potentially life-threatening situation. You get that with a certain class of medication called ACE inhibitors. You could get that even like a year, 2 years, 3 years after you started the medication.
Okay.
So, you know,
Good to
there's
know.
always a temporal association. Yeah, if
Right.
you start getting short of breath and your tongue starts swelling and your lips are swelling and you're taking an ACE inhibitor, call 911
Yeah,
or
I was gonna say,
whatever.
even if you're not taking an ACE inhibitor, if that happens, you probably want to call 911.
Exactly.
So, do you think that people who are taking a lot of medications, or let's say it tends to mostly be older people, that it would be a good thing for them to have like a yearly, like a medication review by their doctor or the
I
pharmacist?
100%. And that's actually why I love the field of geriatrics. I worked with a really well-known physician at a certain institution who I happen to love, and I think he's
Mm-hmm.
hilarious. And he said
Mm-hmm.
to me once, he said, Jonathan, you know what I call geriatrics? I call it internal medicine. And I was like, oh, come on. I mean, his point was that it's
It's right.
basically just internal medicine, but but what I like about geriatrics is there's a real focus on polypharmacy and on functional capacity, so making sure that the patients have the right mindset, that they don't have dementia, that they're functionally able to take care of themselves, activities of daily living. There are certain things that most primary care doctors are good at but not great at, and they're particularly important in the elderly population. These people specialize in it. And
Right.
so I think it's essential because you really have to understand in the geriatric population whether their symptoms are related to their age or to a legitimate organic dysfunction. If they're, let's say you've got an 85-year-old patient who can't lie flat and their legs are swollen and they're really short of breath and and they're coughing and nothing's coming out and they're breathing really really quickly, you can assume that it's probably heart failure and that they really need medication for congestive heart failure and heart disease. But when you start getting into more ambiguous things like not sleeping well, depression is another common one, right? Like, um, I know people who are 90, 95 years old who are as happy as can be, who are living life and are ecstatic with the time that God has given them. And I also know people that they've lost friends, they've lost relatives, they've lost loved ones, and you see that sort of like spark for life sort of fade. Now, is that just because they're elderly or because they actually have real depression and needs to be treated? So again, these are really sensitive and very complex situations that need to be worked out. But unfortunately, what we're seeing is people take, again, I think they're well intentioned and they take this symptomatology of depression. They say, well, if you have a 25-year-old man who comes in with these symptoms, you treat their depression. Why would it be different if it's a 95-year-old man? Treat their depression. They're not sleeping well. Well, if you have a 25-year-old professional who's working in investment banking who is having trouble sleeping, well, this is how I would treat him or her. If they're 95 years old, you should treat them the same way. But that's not the case. And then again, because you tend to have more of these sort of like vague symptoms as you get older, so then the number of prescriptions sort of starts building up because, the doctors are like, okay, treat their depression with that, still depressed, treat it with another one, having trouble sleeping, treat that with another one. And then they, of course, they're at risk for heart disease and lung disease and diabetes and high blood pressure. And, now you're talking about like lots and lots of medications that these people will be taking. So I'm not here to say, no one over the age of 80 should be on any medications. And I'm certainly not saying that depression can't develop when you're 80, 90 years old. Of course it can. I'm just saying that the providers have to be sensitive and thoughtful when working up these patients and making sure that they understand that it's not the same as treating a 25-year-old.
Right. No, I totally hear that. But I got so stuck when you were talking about the age in my mind with the medication that I must ask, knowing that I believe it's Ben Gurion University that you run the cardio rehab exercise or cardiopulmonary rehab. Am I right about
Yeah,
that? I don't know if it was Ben Gurion, but I thought it said Ben Gurion.
yeah, at Soroka.
Okay, fine. So knowing that, I know you believe in exercise. Do you think that as people age, everybody should be on medications? Or do you think diet and exercise plays a role in preventing people from needing that many medications?
I mean, this isn't like is the sky blue sort of question. You can't like paint everyone, across the board with one brush. People should be on medication if they have organic medical conditions that need intervention with pharmaceuticals. So, every single guideline should, and I think most of them do, make real attempts to make sure that they address any lifestyle modifications that can impact the condition that they're treating. No diabetes guideline that I've said says like, to heck with diet and exercise, just go on metformin. Of course they're not going to do that. But it's important, again, to make sure that you're treating people in the best way possible for them. Of course, exercise, lifestyle modifications are essential, and they are the first line for most metabolic conditions. Certainly as part, if not exclusive part of the initial intervention. But again, someone who has diabetes with a hemoglobin A1C of 14, when you see them, you're not allowed to just get by with diet and exercise. So like everything, you have to be thoughtful and you have to be careful and you have to be sensitive. And I think you have to really meet the patient where they are because I travel a lot. So last year I was on a plane every other week. If someone would have said like the only way to treat this condition is to do gym workout 7 days a week for 4 weeks a month, I'd be in big trouble because like I actually couldn't do it. At the same time, they could give me like, let's say 1 or 2 a week, and that I could do even with my travel schedule. So it really just depends on, what condition it is, which patient you're treating, and again, to what extent you can sort of like push them and help them lead a healthier lifestyle, while at the same time understanding that if they can't, then the next best thing is to make sure that they have pharmaceutical treatment.
Okay, well, that definitely makes sense because it's not, I think, that a lot of people can't. I think there are people that won't. And, everyone's built differently, and everyone, as much as I want everyone to exercise and you want everyone to exercise, not everybody will. So,
Yeah, I
you
was
know,
blessed. I was blessed, for better or for worse, with a mindset that just needs to be active. So, I mean, I like shudder to think about what would happen to my family, to my wife, to my coworkers, if for like, I don't know, a month, I just had to sit in front of a desk and just stare at a screen. It would be horrible for everyone. Everyone would be miserable. It would be terrible. So I'm just programmed in such a way. Thank God. Again, God gave me some gifts, gave me some drawbacks. But one of the gifts is that like I have to be out and I have to be active. And so, so while I understand that there are people that are not like that, thank God that's not me. But yeah, for sure, there are people that don't enjoy it. There are people that aren't driven the same way. There's some people that have like great focus and they could stay in front of a computer screen for 12
right.
hours a day. That's not me. So, yeah, for sure. I share my experiences with all the people who I come into contact with. I make sure that they know that even though I'm built a certain way, I don't expect anyone else on the planet to be built the same way, and try to figure something out that makes sense for everyone.
Well, I fully agree with you. The longest I sit in front of a computer screen is when I do these interviews. Other than that, I'm getting up and down, 40 times a day off the floor. Everybody in my office is on the floor. If not the
Uh,
first session, by the second session, you're on the floor. So if you can't get up and down, you'll be able to get up and down by the end.
right.
So let me ask you, if there are people listening here that maybe now it's turned them on to an idea and maybe for themselves, either they know they're taking a lot of medications or for someone they love, and it's kind of freaking them out now a little. Like, what would be something concrete maybe they could do tomorrow?
Yeah. So first of all, I try not to freak out about stuff in general. I'm an intensivist. And so one of my residents once told me, he said, the louder and more chaotic things get in the hospital room, the softer and more calm you have to speak. And in the house of God, they have a, sort of tongue-in-cheek quote that the first pulse to take in a code is your own, right? Take a deep breath,
Heard that actually.
address things objectively, quickly if you have to, but without hysteria. So, so I think that everyone, number one, prescribers should be diligent and thoughtful. Number two, every patient or a patient's family should be their own advocate. Take a look at the medications, see what you have, why they're prescribed, what the indications are, and speak to your provider as to whether you do or do not need them. And again, that's not to second guess anyone or pretend like they don't know what they're talking about. It's simply just to be more informed and educated about the, interventions that you're being prescribed. And I think that's totally reasonable. Nowadays, we have an infinite number of tools at our disposal, from artificial intelligence tools online to again, a lot of the different medication pharmacy tools that people can look up online. You can see almost everything about every medication with the internet that I had to memorize in medical school. So every patient basically knows as much as the physician, when it comes to the laundry list of interactions, medications. I have more experience, right? I've seen more patients. I've prescribed it more often. But certainly you should be your own advocate and you should talk to your provider and see what makes the most sense for you. And I'd say again, the story in the Wall Street Journal that I quoted, which talked about certain medications that people might be prescribing that are causing the side effects, and family members really had to dig deep and understand that it was the medication causing a side effect. Yeah, for sure. If something changes, if something's weird, and again, temporal association, you just started medication, assume it's the medication unless proven otherwise, or talk to your provider or talk to your physician and try to understand, hey, this is what I'm seeing in my loved one. This is what I'm feeling or experiencing myself. Do you think it could be related to the medications that I'm taking? Again, I prescribe medications with the best of them. People come into the ICU, they're on 10 medications that I prescribe right off the bat. At the same time, I do believe that it's important to be thoughtful. It's important to be diligent. And like I started with, I think just there's an integrity that I believe we have to have, that a fidelity to the patient that demands us to be giving them the best care in whatever way that looks, in whatever manner is best for them.
Well, first of all, I love that you said that you think it's totally fine for people to be their own advocates and to approach the doctor, because especially here in Israel, I feel like a lot of times the doctors here really do still feel kind of like they're God. Like there's so few physicians that I've seen here that are like really nice people. Like often, maybe it's because they're busy, maybe it's because it's Kupat Cholim and they're given 3.5 minutes to treat a patient, so they don't have time to hear you. But I find that it's the doctors who tend to be nicer tend to be the Anglo ones. I don't want to say that's only, because I do know one or two very nice physicians who are
my
Israeli.
father once told me, he said, never trust a doctor that won't let you get a second opinion. And I say that all the time to all my patients. If you don't like what I say, no problem. Go check it out. Go ask anyone else. And if they disagree with me, if they have another opinion, wonderful. I don't have a monopoly on truth. All I know is what I know, and I do the best that I can. Maybe someone knows more. Maybe they have more insight. Maybe there's something I'm forgetting about. So absolutely, I think it's really important. And again, people don't really need my permission to be their own advocates. But again, America is like a service nation, and Israel's like a socialist nation. So
Right.
you see that played out
I
just in the
say.
way I think that patients and physicians interact. And for bad, there are positives and negatives. And yeah, again, everyone knows themselves better than anyone else does. So use that capability wisely.
Well, first of all, I think that's great. Second of all, just so you know, just because you might have a different opinion than somebody else, I don't think it makes you wrong. I think it just means two different opinions. Because somebody could come to me with a torn ACL trying to decide whether or not they could do surgery, and I'll give them my opinion and I'll say, you could do this, you could do this. But I ultimately want you to decide because I'm not going to make the decision for you. But like I'm saying, someone else could say a third thing, or someone else could say, no, it has to be that, doesn't mean you're wrong. So I'm just supporting you in the fact that just because someone has a different opinion, it doesn't make you wrong. But I really do like that, because one of the things I'm trying to create for people with this show is that it is very important to me that people are their own advocates. They don't have to agree with the things I'm putting out. In fact, you're probably one of the only regular non-functional medicine doctors I've had on so far. But I really, no,
Yeah.
I'm sorry.
First of many.
First, well, that's what I want to say is that I think it's very important for people to hear everything from everyone and to try to see what makes sense to them. And it's okay to say, you know what, I heard this and I heard this and I'm not sure and I'm going to trust my doctor. But at least you've heard different things. And I think that, unless it's some crazy whacked out thing that really makes no sense at all, and then again, you could still hear it if you want to. But I think that is, I think it is important for people to be involved in at least somewhat in their decision, at least understand what it is that they're going through, what it is that they're getting, and at least understand what it is that they're taking, and not just do things blindly. But again, just because I believe that doesn't mean that everyone else has to believe that because I believe that. But for me, I really want people to try to get that. So I love that you said all of that. I really do. And now I droned on for so long that there was something else I wanted to ask you, and I already forgot what that was. But is there anything you would want people to know? Let's say anybody over 50 or over 60. Like, is there anything else that maybe we didn't talk about that you feel it would be important for people to know?
Yeah, I think that as the people age, the medication side effects are more likely and more severe, and with increased number of medications and prescriptions, more interactions and more common. So again, it started with me just posting an article from the Wall Street Journal that talked about polypharmacy in elderly patients. And my comment was, this is not a surprise to anyone. I'll often admit patients to the hospital, and I'll see like 4 sedating medications to help them sleep. And I'm like, what in the world is going on in this person's life?
They're never going to wake up.
Yeah, like it's like a tranquilizer every day. You know, like that. It's enough to kill me. So it's a real problem. It's a real thing that people need to be aware of. And again, be your own advocate and look and be curious and inquisitive if or your loved one is experiencing things that don't seem normal or out of the ordinary, and you're on a lot of medication. It's definitely worthwhile inquiring about whether or not it's related to them. Like I said, this is reported in medical journals, in the media. It's definitely something that's out there. I do hope that with technology and AI, we'll be able to get a little bit better at making sure that we don't overprescribe medications in the way that we're currently doing right now. But until then, just a watchful eye and keeping aware of what's going on.
Hold on one
Go ahead.
second, because I'm
I know a
choking
good
to death.
pulmonologist.
Exactly. Excuse me, I had a cold last week.
All right. You want to
It's like
talk
the
about
end of it. And I was not smart enough to bring up any water. Okay, one last thing. Do you find that once people are on a lot of these medications, they ever get off of them?
It depends. If they have thoughtful physicians, hopefully they start medications when they need them and stop them when they don't. But unfortunately, too often, things get started and they just keep going and going and going, and they never come off what we call the MAR, which is the medical record. So, you know, again, hopefully people are thoughtful and they take stock of everything that's going on, do the right thing for the patient, and hopefully don't find themselves guilty of illegitimate polypharmacy.
Okay, that was really great. Thank you so much. What does spirituality mean to you?
So it's actually funny, I grew up as an Orthodox Jewish boy in like the Orthodox Jewish world. So spirituality was just, Jewish law, and it was very simple to me, and it was almost second nature. And then as I went through like undergrad and medical school, we started talking to people, and we even in medical school had one of the really interesting things that Einstein did is they had multiple different like educational days to understand like different cultural impacts, different cultures, different philosophies on and things on relationships and drugs and alcohol use, and one of them was religion and spirituality and things like that, which I thought was fascinating. It was the first time I was like, I'm not sure I really know what spirituality means, because it means different things to different people.
Yes.
We're blessed to live in a place where people express their spirituality so differently from, again, what I would associate with like pretty similar to how I grew up, to completely different than anything I would have ever imagined myself enjoying or connecting to. And so I think more than anything, uh, it's about, if we could use the medical jargon for a second, it's about going a little bit beyond the biology. So when you have a patient and they need a medication, to me, it's not really so spiritual. But when you connect with the patient, when you have like an emotional connection with them, and you bond with them, that's beyond the biology. That to me is almost like a spiritual connection. That's getting to that level of spirituality, or that realm of spirituality, I would say. Um, and it's the same thing like your daily life. If you are doing something mechanically, then it's probably not particularly spiritual. But then once you get just above the science, above the anatomy, above the biology, then you're in the realm of spirituality, and that could be interacting with your family members. It could be singing a song, playing music. It could be prayer. It could be meditation. It could be again just having like reading a fascinating book and like having an insight. All of those things are transcending just the basic science. Um, is I would say like the start of spirituality.
I think that if you've actually connected with your patient, I think they will get better quicker, personally,
I totally agree.
you know? So, lastly, if people want to contact you, how can they do that?
Smoke signals, you know,
Perfect.
yeah, these days it's like impossible to hide, right?
It's true. That's actually
I'm
true.
calling my personal cell phone like, "Hey, Dr. Wiesen, I'm your patient. I just like found your phone number." And they're okay. So, the smoke signals maybe used to work, but these days there's just no end to, how people can connect with other people. A lot of the work that I do is in the hospital. You're admitted to the hospital, you get stuck with me as your doctor. But again, that's part of where you create that connection and create that relationship. And so, appreciate you having me on and giving me the
Thank
opportunity
you.
to, blabber on about a lot of these things. Hopefully some of it was useful.
A
Hopefully it
lot of
helped.
it was useful. I'm sorry that I had a choking fit, on screen, but that's okay. Thank you so, so, so much. I really appreciate your coming on.
All right. Thanks, Dara. Take care.
Thanks. Hey guys, I am so excited to have one of my absolute favorite people, Rabbi Peretz Segal, back with us today to do another extra. I always love his insight and his Torah, and I cannot wait to hear what he has for us today.
Thanks, Dora. It's great to be here. I'm excited to explore together.
Me too. So this is like not my typical topics. I've had you do some, really off, maybe off the wall things. This is almost traditional, conventional medicine, right?
Mm,
Polypharmacy, what happens when people are taking too many, medications. So it's a little
yeah,
different, but I love to give people information. So it's all good.
great. So yeah, I mean, I think it's definitely more kind of the standard thing, and I think it's a reality. It's a reality that I'm living with in terms of dealing with aging parents, with the amount of medications and the complexity of medications, especially when you're dealing with parents who have cognitive issues. It becomes a huge thing.
It's true. That's really true.
Mm.
So, tell me, what does the Torah have to say about all of this?
So, I was thinking about this. There's there's a bit of like we can get. I'll start off being esoteric. Why not? And the Gemara in Kiddushin says when it says in the verse which is saying Shema v'samtem es dvara ele, when you'll put these words on your heart, it breaks up those two words samtem, and it reads them as sam tam, which means drug perfect, the
Wow.
perfect drug. And it's a lovely expression, and it's so, I suppose, highlighted by the notion of polypharmacy, because I don't think we appreciate the beauty of a drug that doesn't have side effects. And I think one of the complications of polypharmacy is that very often symptoms which are not, a person's taking all these drugs and then a new symptom comes up and they want to administer another drug to treat the new symptom, but really that new symptom is a side effect of one of the other drugs. So then you introduce a new drug to treat the symptom, which is really a side effect of the old drug, and it becomes the thing that's meant to heal can actually hurt. And the power of, I suppose, Torah as a spiritual system in a holistic fashion is it's got many components to it. And in a certain way, it's comparable to polypharmacy because we are so complex as individuals. And there's so much going on inside of us. And there's, as it were, so many conditions that we have to treat. And therefore, you may start to think, well, if I'm starting to put the system into my life to get more calm, and Shabbos is just kind of going to get me there. But the problem is, Shachris is going to wake me up in the morning. And maybe that's going to be counter indicative to my Shabbos. Or maybe my desire to keep kashrus is going to impact my freedom of needing to eat when I feel, whatever it is. There are all these complex array of different things which are literally kind of compounded by the complexity of our life. And therefore, it would be natural to assume that Torah is actually a spiritual polypharmacy nightmare. And comes the Gemara and says, no, samtam. Nothing has a side effect. Nothing is counterindicated. That it requires an overview, but everything fits together. And this brings to mind another Gemara. The Gemara says that it quotes a pasuk from Shir Hashem, it's referring to in this love song between the love and the beloved. It says your neck is like the opening of it's like a rim, it's like a pomegranate. And rakasech, that expression, the Gemara darshans to mean afilu rekonim shebochem, even the empty ones of you, malaim mitzvahs kerimoy. You fold up with mitzvahs like the seeds of a pomegranate. And the pomegranate's got hundreds of seeds, and even the people who are empty are full. So the question is, well, if they're full, so why are you calling them empty? The nature of a pomegranate is that each seed is differentiated. You know, you open up an apple, it's the flesh is just solid. A pomegranate, each seed has got its own little container, and it exists within this bigger fruit, but it's very, very differentiated. There's no coordination between the seeds as you would in the normal flesh of a fruit. And so the emptiness of the people who are full is that there's no coherence. There's this mitzvah, and then there's this mitzvah, and then there's this mitzvah, and that makes you empty. So there can be, if you get Torah wrong, there can be a polypharmacy issue because you're doing this thing and that conflicts with that thing because there's no underlying governing, unifying force. And that governing, unifying force is Rachmana Libaboy. HaKadosh Baruch Hu wants our heart, which means he wants our experiential, real, authentic connection. And the ritualizing and the roboticizing of Torah and saying, well, I have to do this and I have to do this, which all of those things are not prescriptive, they're descriptive. The reason why the mezuzah be put at this place with these lettering is because otherwise it doesn't work. It just doesn't work. It's a delicate system, and everything has to be done in alignment with its source. It's describing a reality. But when you take it as a prescription, and you look at it as, oh, I have to do this, and I have to do that, and I have to do this, and I have to do that. No, then everything starts conflict because you've lost the essence, you've lost the core, the unifying force leaves, and then you get into a big pharmacological mess.
That's great. Yeah. Thank you. I really like that. That's great. That's a really great comparison. I love it. Thank you so much.
It's a joy and a pleasure, as always. And just wishing you continued success with the wonderful, wonderful work you do. It really is so helpful and so beneficial and so entertaining and interesting.
Thank you so much. This podcast is for informational purposes only. Please seek guidance from a trusted healthcare professional. By listening to this podcast, you release Holy Health and all of its guests from all liability. I'd like to thank Yakir Abelow for editing this podcast.